Okay, good afternoon, everybody, dear friends and colleagues. First of all, I would like to talk about this hard situation where all over the world is suffering from the same issue. All are praying to pass quickly these hard days, and really we are praying for all the victims that passed away. Let's be positive now. I would like to thank Klockner Education that organized this webinar, the scientific webinar that will begin today and continue on Monday 13. We hope that this scientific event will be fruitful for all of us, sharing with you, dear friends and colleagues, current and scientific knowledge in this field. This session will be divided into 3 parts. I will begin by the ridge splitting technique. After that, Dr. Fabrega from Spain, he will speak about occlusion, problems and solutions. And after that, Dr. Fragola from Italy, he will speak about the Vega Plus contactile surface. Before I begin, I want to thank also Klockner Company in Spain and Klockner Dealer in Lebanon, represented by DMS for this scientific event. So let me begin with meditation. So I will speak today about ridge splitting technique for horizontal ridge deficiency. First of all, what are the objectives in general for all our treatments? We should all the time have recalled all the data, the clinical data, have a very good diagnosis to, in order to establish the appropriate treatment plan with excellent clinical skills. Secondly, we should really know everything about the anatomy, because where we are placing our implant, we should know very well our biology, because after our procedure, what will happen to this patient, and we should have really the good surgical and prosthetic principles. Also, we should choose the best therapeutic modality in order to achieve a prosthetic-driven implant, and this is the key of success of our work, because at the end, the patient didn't know what is the implant, he wants a crown. So we should place our implant where the future crown should be. And at the end, we should have a successful, stable, and predictable result over time. So let's begin by a little summary about what will happen after extraction. Following tooth extraction, we all know we will have hard tissue alteration and soft tissue alteration. I don't want to tell you that many, maybe more than 100 articles spoke about this issue in animals, in humans, and I want to select only one article. It's a systematic review done by Tan in 2012, where he discussed about the hard tissue, soft tissue, what will happen, and what will happen to the hard and soft tissue. Results are, in horizontal bone loss, the mean bone deficiency will be around 4 millimeters. While with the vertical bone, it will be around 1.5 millimeters. And the buccal plate will resorb more than the lingual plate because it is thinner, and it's due to the presence of the bundle bone, And all this alteration, hard tissue alteration, will happen during the first 3 to 6 months, and it will follow over time during the life of the person. Concerning the soft tissue, again, we will have an alteration concerning the soft tissue. If you are dealing with a thin buccal plate, we will have a thickening in the soft tissue. And if you are dealing with a thick buccal plate, the soft tissue will be the same. So after this little introduction, let's do, when we have a horizontal ridge deficiency, to make a diagnosis and appropriate treatment plan, we should know what kind of deficiency, horizontal deficiency, we are dealing with. For this reason, I choose really a very nice classification done by Chapasco in 2018, where he divided bone width alteration into 4 classes. Class 1, when we have a mild bone width deficiency, where we can place our implant in ideal prosthetic driven axis, and we don't need any bone augmentation. In some little cases, we can make a soft tissue augmentation. While in class 2, it's the moderate bone width deficiency. In this situation, we are able to place our implant also, but we need to make a guided bone regeneration. So it needs bone augmentation, and in some cases, bone augmentation with soft tissue augmentation. In class 3, we have more severe bone width deficiency. In this class, we cannot place our implant. We have to make it a staged approach. So we have to reconstruct our width deficiency by guided bone regeneration or bone block, whatever. Wait 6 to 9 months, and after that, doing our implant. And in the last classification, the class 4, when we have a combined horizontal and vertical bone deficiency, after extraction, it's stage approach 2, we need to wait 9 to 12 months because it's more severe, and after that, we can do our implant. So, for this reason, I will talk today about only class 2 because I can place my implant and simultaneously I can make the bone augmentation. There is 2 ways of doing guided bone regeneration with non-resorbable or resorbable membrane or ridge splitting technique. Today, I will concentrate only, I will focus about the ridge splitting technique, and I will talk first of all about the indications. To do this technique, we have only to have ridge defects without any vertical ridge defects. Secondly, minimum width, we should have at least 3 millimeters of bone in width and at least 1 millimeter of trabecular bone. If we don't have 1 millimeter of spongious bone, we cannot do this technique because if we try, where we are dividing the bone will fracture. So we need to have 1 millimeter of spongious bone with adequate vertical height and no severe concavity lingually or buccal. Another indication with it's very important, the relation between the maxilla and the mandible, we should have a very good relation. It means the implant that we will place when we are doing the splitting technique, it should be placed in ideal prosthetic axis driven. If we are not able to do that, we don't have to make this technique. We move to the guided bone regeneration. We wait 6 or 9 months, and after that, we place our implant in the ideal position. And you have to know, we all know that in the maxilla, this technique is better than, it's more easy, more flexible than the mandible because we have more spongious bone and the bone is more elastic and more flexible. If you look at the CBC mandible, In this condition, we cannot make the split technique because we don't have this 1 millimeter of spongious bone. So it's a contraindication here to make this technique. What about the advantages? We have many advantages because we are allowed to place our implants simultaneously, and we can maximum preservation of the existing bone. This amazing technique, why I like this technique? Because when we divide the bone into two parts, the implant, we place the implant with a primary stability, and the implant will be surrounded by a bone buccally, lingually, or palatally. And it will reduce overall treatment time, reduce the number of surgical procedures. It means it will reduce the cost. The disadvantages, it's a very sensitive technique and it requires experienced clinicians. I will start my presentation with the first case I selected in the mandible, and I select a very hard case. Really, it was a very tough case. This was a female, 33 years, no systemic disease. Her patient demand restore her missing teeth. So if we see the panoramic panorex, we have to evaluate the area. In the region of 36, we have, in the region of 36, we have 4 millimeter of width of bone and 10 millimeter of length. And in the region of 37, we had around also 4 millimeter of width. So the treatment plan was ridge splitting technique with implant placement and guided bone regeneration at the same time. After 4 months, second stage surgery, 36, 37, and after 1 month, the final crown. I will begin by a little video showing the technique. So after anesthesia, we do full thickness flap, and after that we have to make the release periosteum incision to have tension-free flap, buccally and lingually. And after that we start with our piezo surgical, and we do our horizontal cut, and we have to do 2 vertical cut, one mesially and one distally. It's obligatory in the mandible because the bone is very hard and very cortical. And after that, we start with the chisel. We make tapping with 3 diameter of chisel. And after that, as you see, we make the ring process. And here I want you to know that the speed should be not exceeding 500. Because in low speed, we conserve more bone. And we place our implant as usual. And here the primary stability was very high in the first implant. I was obliged to place my implant more apically with the ratchet. And after that, we make our guided bone regeneration like the classical one. So we make the decortication of the buccal plate, and we place our resorbable membrane lingually, and we place our bone substitute. In general, we select a xenograft material for this kind of situation because we want a scaffold, we want a bone volume over time, and we finish it by suturing the area. Here we choose a PTFE 50 non-resorbable suture. And this is the result after 4 months. As we can see here, look at the bone, look at the amount of buccal bone that we can have after this technique, using at the same time the guided bone regeneration. And if you see, the implant was placed in ideal prosthetic accident. Not to do this, make the guided bone regeneration and the implant placement after. So this is the situation after suturing, after 1 month. And here is the nice architecture of the soft tissue. Impression, screw retained crown, And this is the final result of this situation. You can see here the amount of buccal bone in the 36 and 37. So we will see it also, see the same case here, but I will go quickly. Here, look the thin buccal plate that we have from the beginning. We had 3 millimeters of width. This is the vertical fracture that we have to do distally and mesially to facilitate the gap and to facilitate the bone fracture. And in this particulated case, it's more easy if we use something we call it the bone condenser to open also the gap. Okay, this is the look at the thin bone before doing our guided bone regeneration. We have maybe 0.5 millimeter of bone, but after doing our guided bone regeneration, this is after 4 months, look at the amount of bone, and one of our implant, we have occlusally presence of bone in the occlusal part, and this is the amount of buccal bone after the guided bone regeneration. Okay, we see all this impression. This is the final crown. Okay, up and down, and this is the final X-ray. Look at the amount of bone on 36 and 37. I will pass to another case. This one also, the patient was suffering from his left upper teeth. She had pain. After a good analysis clinically and radiologically, and after studying the CBCT, she has a vertical fracture on the premolar, and she had a problem with his perforation on the 27. So the decision was to make extraction of 24 and 27 and to place 3 implants, 24, 25, and 26. And here is the X-ray, and it's very important to do this kind of study. So what I said before, diagnosis and the appropriate treatment plan, because we have to record all the data, clinical data, radiological data, and we analyze everything. We choose our appropriate technique. For example, in this situation, we can go for the split technique because we have 4 millimeters of width, and we have a big amount of spongeous bone in between. So the decision was to make extraction of 24 and 27 and place our implant on 24, 25, 26. This is during the procedure, the splitting technique procedure. Here, after enhancing the space, and here, after placing the 3 implant, no buccal bone, but here it's nothing, it's one wall defect, only the buccal plate was absent. So after all that we do, it's very important to do the periosteel, the incision, the mucoperiosteel incision. Why? To eliminate all the muscle from the periosteum and to let the flap free. So we will close after our guided bone regeneration. The flap will close with tension free, without any tension, because if there is tension in the flap, after a few days it will open and it will make for us a very big problem. So one of the key of the success of the guided bone regeneration is to liberate the buccal flap, and in the mandible to liberate the buccal and the lingual flap. Here to see how much we can do our flap moving coronally. And here, where after doing our guided bone regeneration, this is after X-ray, after the procedure, after 4 months, we had after 4 months lack of keratinized gingiva, and it will happen oftenly when we do our guided bone regeneration. So it needs to make a free gingival graft to this area. So a free gingival graft was done, harvested from the palate, and for this, the thickness did not exceed 2 millimeter, 2.5 millimeter. It means 0.8 millimeter of epithelium and 1.2 to 1.5 millimeter of connective tissue, not more and not less. If it's less, the free gingival graft will resorb, and if it's very thick, it will be during the healing lack of vascularization, and it will resorb or it will make a necrosis. So the ideal thickness is 2 millimeter for free gingival graft, and if you are dealing with the connective tissue graft, we have between 1.2 millimeter and 1.5 millimeter, and this is the donor side. All the time we have to make suture, we have to put something inside. We put the gel foam here and to arrest the blood, and we should tell the patient to put the gouttière during this 15 days. And this is the free gingival graft after suturing. And here, after 4 months, we took another CBCT to evaluate our guided bone regeneration. And as you see, we have amount of buccal bone in our 3 implant. And this is the nice keratinized gingiva after 2 months of our free gingival graft. Second stage surgery, here the X-ray, and here after 1 month, the final prosthesis, the nice architecture of the soft gingiva, here the impression and try in, and here the final result with the final bridge. And here is also the X-ray after the final prosthesis. My third topic, my third case is in the upper. We saw 2 cases in the mandible. Now we will see 2 cases, the same cases, but this one he is not finished yet. I will show you only one part, and I will show you a video how we do our guided bone regeneration after doing our split technique. So the patient came to us to to replace her denture by fixed prosthesis, so they need implants, and in the mandible the same thing. So the decision after studying the case with the prosto department, this is a case done at the Lebanese University, and when we have a complicated cases like this, we go with the prosto department and we do the planning together. Here we decided to put 6 implants in the maxilla and 3 implants in the mandible. They divided into 13, 14, 16, 23, 24, and 26. Here are the photo of the case, the relation between the upper maxilla and the mandible. And here are the CBCT concerning the 16, 14, 13. I will show you only this clinically, the surgical part of the 16, 14, 13. For the 16, we have enough bone width and height. For the 14 and 13, we have deficiency, a horizontal deficiency. So we need to make a split ridge technique and accompanied by the guided bone regeneration. This is the case during the surgery. Here, I want you to see that we have only 3 millimeters of bone in width. So we decided to make the same technique, the same procedure, splitting technique. And we did here also 2 vertical incisions. Will be more easy to infract the buccal bone from the palatal. And look how much we can enhance and augmented the space when we are doing our splitting with the chisel. Here we have 5 millimeters of thickness with the space. The drilling, we place our 3 implants in ideal position. Here are the implants. and look at the amount of guided bone regeneration that we can make after placing our implant. All the time for the guided bone regeneration, we choose a resorbable membrane, but with a long time option. One time, it's important to choose such kind of membrane like pericardium native membrane, because we need this scaffold, this sandwich that we make, we need that it will stay at least 4 months. Why 4 months? Because during this 4 months, the newly formed bone will begin mineralized and it will be very stable. If the membrane will resorb after 1 or 2 months, the big amount of the bone gain, of the bone augmentation that we did with our bone substitute, it will resorb, because after 1 or 2 months, this bone is not very well formed and it's not very well mineralized, and the mass part of this bone will resorb. So it's very important, a resorbable membrane with a long time of resorption. And also we have to stabilize this membrane, because all the new study, if we didn't stabilize this membrane with pins, the bone substitute will disappear, and the big amount of guided bone regeneration, we will lose this amount of regeneration. So let's, at the beginning we had a 3 millimeter, and now at the end we have some area 8 and in some area 9. I am sure it will resorb maybe 3 millimeter. At the end we will have maybe 6 millimeter of bone. And this is very important, because all the study now in the anterior zone, we should have at least 2 millimeter of buccal plate. If we can have more, it will be safer actor, more safety. And for the posterior area, we should have at least 1.5 millimeter to have the stability of our result over time. I will show you another video also here to show how much we can enhance the space and how much we can divide the bone. Here, the drilling, the speed should be not exceeding 500 speed, because it will conserve the bone. Here we are placing 2 parallel implants. Okay, look, we still have 1 or 1.5 millimeter of buccal bone and 1.5 millimeter, 1 to 1.5 palatally. Our 2 implants are surrounded by native bone. And after that, we do our guided bone regeneration. Here, the resorbable membrane was fixed by 2 pins palatally. And now I am reconstructing the area buccally, and I will fix now this resorbable membrane by the pins. And by the way, Klockner pins are, I'm not making a publicity, but Klockner pins for the mandible, they have a special pins for the mandible. They are really amazing. Here, after look how stable is the membrane, stable the bone substitute underneath, and here after releasing the periosteum, tension free, so we can be more safe with this technique. Now I will finish my presentation with this case. This is a patient. She is suffering also from the upper. She had a denture. She wanted to replace her denture with a fixed prosthesis. And she had also a problem, a dentillus area in the 2 regions, left and right. This is the patient, the profile of the patient with and without denture. And this is the situation, the clinical situation. Denture in the upper and that partial denture in the lower. So a dentillus area from left, right, dentillous maxilla. Clinical photo without the denture, radiological photo, radio, and this is the analysis that we want to do for the CBCT. So we decided after also this case was done at Lebanese University. We decided with the prosto department to place 8 implants in the maxilla and 6 implants in the mandible. Let's begin with this implant in the maxilla. 16, 14, 13, 11. As you see in the 16 area, we have enough bone in which for the 14, 13, 11, a guided bone generation, or we did here the split technique. The same in the right, we have to make splitting technique between anterior teeth, and then we have to make 3 split technique. One between 14, 13, one between 11, 21, and the other between 24, 23, and 24. The big question now, what will wear the patient after doing this procedure? We have to think about everything because this patient will stay around 5 to 6 months after this heavy procedure. We have to think that this patient needs to eat. So we decide also to place 4 mini implants, temporary implant, in between, it means in the region 15, 22, 25, to put his denture into a locator, into the mini implant. And for the mandible, the prosto department decide to place 3 implants in region 35, 35, 34, 35, 36, and 46, 45, 44. There is no problem. We had width and we had bone, so straightforward, no need for any bone augmentation in this area and the mandible. Here is the photo. We decide to place 16 mini implant in 15, 14, 13, mini implant at 12, mini implant 24, and mini implant at 25. 3 split technique between 14, 13, 11, 21, 23, 24. Okay, this is really from, it's very, very, very tough surgery, and the patient should be a yoga person because it will take around 3 hours between the surgical procedure, and the most difficult part will be the prostical part. And here I want to thank the resident in perio department and prosto department that helped me doing this case, and also the prostodontic department. So after incision, we had a little cyst between in the anterior region, and here in the region 16, 14, 13. Here we did our first split procedure, same way of thinking with the chisel. We divided the bone into 2 parts, one buccally, one palatally. Here are after the drilling. In the anterior area, we had a very big cyst in the implant number 11. So we did after that the split in the area 11 and 21. And we did also in the region, as you see, 23, 24. Here are the implant placed in place, 8 implants. And here, after placing the implant, we want to do the guided regeneration. The same technique, the same principle. We put xenograft material, we put resorbable membrane, we stabilize our resorbable membrane. And here the anterior region, 24, 26, and after suturing and the mini implant with locator, and this is the denture of the patient. The resident in the prosto department, she eliminated all the fringe, and she placed look how the patient looked after this big surgery. She had a stable prosthesis. She can eat from the first day because all the implants are underneath, and they are not. They have any pressure on our gland. This is the occlusion view, and this is how it looked, the denture after the surgery. Okay, this is after 2 weeks. I want you to see the nice healing after 2 weeks of this surgery. In the mandible, we place 3 implants as recommended by the prosto department, straightforward implant, and we did an immediate temporization because the patient needs to eat. The only mistake that we made with this case, we start with the maxilla, we had to start with the mandible, make a full arch, occlusion into the arch, and after that, make the regeneration of maxilla. It will be more fruitful for the patient. But nevertheless, we did our 3 implants here. The resident make a screw retain 3 crown. And the other side, we place 3 implant and here cemented crown. Only to see. And this is the follow-up, how it looked the patient during the phase of healing. We have a nice healing in the upper and in the mandible. After that, we make the 7th stage. You can calculate the bone, how much we have, the amount of buckle in the 3 area after this technique. This is the suturing after the 2nd stage. And we did also free gingival graft over 24-26. And this is the final result. We decided before to make a full ceramic crown. So for that, we placed 8 implants, but I don't know in the prosto department why they moved to hybrid. Maybe they didn't have enough lip support, I'm sure, for that. So it will end by a hybrid prosthesis. This is the left and right side, and this is the upper and the lower. And here the smile of the patient. This is before, how it looked before, and this is how it looked after this big reconstruction and rehabilitation of this full mouth, and at the X-ray before and after. And my message is, whatever you want to do, whatever is the procedure, you can choose whatever procedure, but before making the treatment plan, you should make a good diagnosis. And we have to know that this treatment plan should be stable over time. All the time you have to think about the buccal plate. If you want your result to, if you want to maximize your aesthetic result and to have a stable result, you have to rebuild your buccal plate. So whatever the technique, if you choose guided bone regeneration, bone block, split technique, whatever you are choosing like as technique, you have to think about this buccal bone. To have stability, you have to rebuild this buccal bone. And I want to thank all dear friends and colleagues, and please wash your hand and stay home. Thank you very much.
Okay, it was a very nice presentation from you. I did like it very much.
Thank you.
There are some questions here, so I will try to make them to you, okay? The first one says, the drilling speed, how much should it be when you drill after making this cortical split?
Not more than 500, between 400 and 500, because if we go full speed, it means 800, 900, the buccal plate will fract. And when they will try it, when we make it very slowly, the buccal plate will move with the drill, and we conserve the maximum of bone in the buccal plate and in the lingual plate.
Okay, there's another question talking about the PSO surgery when you make the corticotomy.
Yes.
Yes. How deep do you go with your
Very good question. I forget to if we are dealing with a height of 10 millimeter, we don't have, with the piezo we have to be 5 millimeter deeper, not more than this, because the principle is to conserve at least 3 to 4 millimeter native bone, and this native bone will assure the stability of our implant. We don't have to go more deeper. If you have 10 millimeter, 5 millimeter, or 6 millimeter are more than enough. If we have 8 millimeter, 4 millimeter, it's more than enough.
There were 3 questions related to the buccal bone plate. What happens if it breaks? What do you do?
One time it will happen at our university, and we use the screw like the Fuad Khoury technique. Yani we transform the buccal plate into a cortical lamina, a lamina cortica, and we place it with a screw. We screw it with 2 screws, not pins. We make a hole and we screw it like a lamina cortica.
Okay. There's only one doctor asking, did you remove the temporary locator implants after the surgery, and how did you do it?
Yeah, it's very easy. Okay. It's very easy because it's very easy. We unscrew it, we make a local anesthesia, and we unscrew it. It's very easy to unscrew this mini implant.
Okay. There was one talking about interim restorations, but you showed in this case before. And also, there's one question talking about, is it possible to integrate fully guided implants placement with this technique?
Oh,
no way.
No way. Really, it's a very sensitive technique, and it's it's a sensitive technique. Not fully guided, I don't think so.
Okay.
We hope so, but till now it's...
There are 2 more questions. One is asking about the depth, of the implant placement after doing this technique. How deep do you place the implant, the shoulder of the implant, because you have been using bone level implants? How deep do you place it? 2 millimeters, 3?
Yes. With this technique, if you see, we have one implant in the maxilla, where we lost 1.5 millimeter of our cervical bone. Why? Because I placed the 2 implant flashing the bone. Normally, we have to place our implant 1 millimeter below the bone.
Okay. And there's 2 questions talking about, do you use, when you make the bone grafting, do you use a mixture or just autogenous bone or biomaterials? And which ones? Bovine?
If I am doing the guided bone regeneration alone, without placing my implant, I go for a 50% autogenous bone harvesting from the area and 50% xenograft material. But this particulated technique, because I am enhancing the bone and I'm not loading this bone, I do only xenograft material because I need it as a scaffold, not more than this. But if I have to make guided bone regeneration, because my future implant will be in this new bone, I make a mixer. I mix my autogenous bone with my xenograft. It will be better. It will be more safe.
Another question is combining this technique with platelet-rich factors.
I don't have big experience with platelet-rich factor, but from the literature, and excuse me to tell this, platelet-rich factor is very well for soft tissue and not for hard tissue.
Okay.
My opinion.
The last question, which is the difference between ridge expansion and ridge split?
Ridge expansion
and ridge split.
Ridge splitting when you divided the bone. Ridge expansion when you use only the condenser.
Yeah. Okay, so I think this is the last question. Well, there's another one, lately question, success rate. Yeah, asking your success rate.
Really, till now, we didn't, I'm not, till now, we didn't lose any implant with this technique. We have one of this implant, I told you, we lost 1.5 millimeter cervically from the implant, but till now, I don't have any failure implant.
So thank you for your presentation.